Good afternoon, everybody. Today we will have a special session in ISIC distance learning. Today we will talk about the dealing with the calcified lesion in 2024. We will have two lecturers and one presenter and three panelists. The two lecturers is Dr. Fauzi Yahya as ISIC chairman. And then the second speakers is our special guest lecturer, Dr. Yeo Khung Keong from the National Heart Center, Singapore. Thank you very much, Dr. KK. And then the presenter will be Dr. Tami. Yeah. And then three panelists is Dr. Yahya Berkahanto, Dr. Bahrudin, and Dr. Muhammad Andi Yasin. So each presenter will have 20 minutes talk, and then we will discuss the case. The case presenter will have around 15 minutes, and then we will stop in between the presentations. Okay, the first is Dr. Fauzi Yahya will give us some highlight on the intravascular imaging in calcified lesion. Dr. Fauzi, the time is yours.
Yeah. Thank you, Dr. Rifqi. I'm going to talk about the diagnosis of calcified lesions in 2024. I'm going to talk in Bahasa Indonesia to elaborate more about the calcified lesions. Can you hear my sound?
Yes, very good.
Okay, thank you.
Very clear.
Ya, baik. Terima kasih kesempatan yang diberikan. Saya akan berbicara tentang diagnosis coronary calcified lesi pada yang kontemporer, ya. Nah, sebelum kita membahas hal tersebut, kita ketahui bersama bahwa tujuan PCI itu pada dasarnya ada tiga, ya, yaitu ketika kita mampu menghilangkan simptom dan iskemi, juga tidak menyebabkan komplikasi. Dan juga diharapkan tindakan tersebut tidak short term durations, namun long term result. Jadi hasilnya bisa berjangka panjang tanpa komplikasi dan menghilangkan keluhan dan iskemi. Namun persoalannya, kalsifikasi itu sering menimbulkan persoalan di dalam mewujudkan tujuan dari PCI tersebut. Kita lihat ini adalah unexpanded stent ketika kita tidak mengapresiasi adanya kalsifikasi yang berakhir dengan stent tidak berkembang ataupun minimal stent areanya tidak adekuat. Stent yang tidak adekuat di dalam berkembang, ya, mengembangkan stent yang tidak adekuat, maka dapat memprediksi durable ability-nya. Jadi stent dengan minimal stent area yang kecil akan mudah untuk mengalami instant restenosis dan bahkan pada keadaan yang ekstrim bisa menyebabkan instant thrombosis. Dan di samping itu terdapat lesi-lesi kalsifikasi yang bisa menyebabkan komplikasi yang bahkan fatal, diantaranya adalah perforasi. Nah, biasanya kasus-kasus ini disebabkan karena adanya adventitial stretch pada eccentric kalsifikasi, ya. Karena kita tahu bahwa sisi yang terdapat kalsifikasi itu tidak bisa mengembangkan diri, ya, sehingga ketika kita melakukan tindakan pada balun atau stent, maka balun atau stent tersebut mengembangkan di sisi yang sehat ini sehingga stretch hingga ke media dan kemudian bisa ke adventitia dan kemudian terjadi perforasi. Nah, sehingga dengan adanya kalsifikasi ini potensial akan menghambat kita di dalam memenuhi tujuan daripada tindakan PCI. Karena itu penting kita melakukan identifikasi dan assessment kalsium. Nah, kita tahu sebagian besar kita melakukan assessment kalsium ini dengan melakukan angiografi, dengan melalui angiografi. Dan kalau kita melalui angiografi, data memperlihatkan bahwa kalau kita mengatakan ini moderat kalsifikasi, maka terdapat radio opacity eh, yang kita bisa lihat. Nah, juga kita bisa mengklasifikasikan severe kalsifikasi walaupun jantung tidak bergerak, ya, jantung tidak motion, ya. Jadi kita masih bisa melihat kalsifikasi tersebut. Dan biasanya kita menjumpai apa yang disebut tram track, seperti kita lihat seperti ini. Namun sayangnya, angiografi ini tidak sensitif dalam menentukan plak distribusi dan komposisi. Sensitivitasnya berkisar 48% dengan spesifitas 89%. Jadi terdapat kasus-kasus kita tidak mendeteksi kalsium, ya, pada melalui angiografi. Dan data ini memperlihatkan bahwa assessment angiografi visible kalsium ini, kalau kita mendapatkan dari angiografi kalsium, maka kita lihat bahwa kasus ini, kalau kita mendapatkan kalsifikasi melalui angiografi, maka kemungkinan bahwa kalsiumnya lebih tebal, ya. Kalsiumnya itu tebal dan kemungkinan bahwa tidak bisa tercrack, ya, oleh balun biasa. Nah, karena itu adanya kalsium secara angiografi merupakan petanda stent under expansion. Jadi kalau kita mendapatkan kalsium pada angiografi, kita harus berhati-hati tidak melakukan tindakan pemasangan stent ataupun balun begitu saja, karena kita harus eksplorasi lebih lanjut. Namun kalau kita tidak mendapatkan kalsium, tentunya harus kita melihat dari berbagai view angiografi. Kalau kita tidak melihat adanya kalsium, ya, maka kemungkinan besar bahwa dia stent dapat ekspansi dengan baik walaupun tanpa tindakan aterektomi. Jadi kita harus betul-betul memanfaatkan angiografi ini untuk menentukan apakah kita akan melakukan tindakan aterektomi, potensial tindakan aterektomi atau tidak. Nah, kalau kita lihat pada sirkumfleks ini tampak lesi kalsifikasi, dan kadang kita bisa mengetes menggunakan balun dan kita lihat bahwa balun tidak berkembang dengan baik. Pada keadaan demikian, sebaiknya jangan diekspansi lebih, ya. Karena kalau dia terjadi diseksi ataupun perforasi, maka sudah sulit kita untuk mengatasinya, ya. Nah, ini lihat, ini ada balun. Jadi balun tes ini bisa kita gunakan kalau ternyata balun tidak berkembang, maka kita harus berhati-hati untuk melanjutkan tindakan ini. Seluruh algoritma dalam kita melakukan tindakan pada lesi kalsifikasi mensyaratkan adanya coronary imaging. Namun, coronary imaging bukan sekedar untuk mengidentifikasi adanya kalsium atau tidak. Dia memiliki manfaat yang lebih dari sekedar itu. Jadi, selain dia mendeteksi adanya kalsium, coronary imaging juga dapat memberi informasi kepada kita pola dari kalsium tersebut. Dan kemudian juga dapat menentukan strategi apa terhadap vessel yang mengalami kalsifikasi tersebut. Apakah memerlukan aterektomi atau tidak? Kalau memerlukan aterektomi, apakah kita dapat menggunakan masing-masing ini? Apakah dia rotablator, ataukah OAS, ataukah IVL? Nah, selain itu, peran dari coronary imaging juga dapat menentukan risiko prosedur yang kita lakukan. Apakah potensial terjadi perforasi dan bagaimana mengatasinya. Juga di dalam menentukan apakah kemungkinan terjadi slow flow atau tidak. Jadi manfaat dari intracoronary imaging sekali lagi bukan hanya calcium presence, namun juga calcium pattern, calcium modification strategy, procedural risk. Nah, juga peranan intracoronary imaging juga untuk menentukan apakah modifikasi kalsium yang kita lakukan telah berhasil atau tidak. Ini penting sekali. Kalau kita melakukan atherectomy, apakah itu rotablator atau orbital atherectomy, kita harus juga menentukan apakah tindakan tersebut berhasil atau tidak. Nah, keberhasilan itu nanti ada parameter-parameter yang berdasarkan intracoronary imaging. Yang terakhir, peranan dari intracoronary imaging ini juga dapat dimanfaatkan untuk menentukan optimalisasi dari tindakan PCI. Apakah tindakan kita pada lesi kalsifikasi ini sudah optimal atau tidak? Jadi diagnosis kalsifikasi ini tidak hanya kita menentukan sekali lagi kalsium, tapi juga menentukan hal-hal yang demikian. Nah, kalau kita lihat bahwa terdapat berbagai modalitas imaging di dalam mendeteksi dan mengakses ya kalsifikasi. Masing-masing memiliki kelebihan dan juga terdapat kekurangannya. Saya akan mengelaborasi satu demi satu. Tadi angiografi kita sudah saya sampaikan. Nah, kalau kita melihat adanya kita mendapatkan apa yang kita sebut sebagai cardiac MSCT sebelumnya, itu akan sangat bagus. Karena cardiac MSCT itu didapat menentukan adanya kalsifikasi, ya. Jadi Hounsfield ini unit ya yang lebih dari 400 ini membuat potensial kalsifikasi tidak dapat berkembang, stent tidak bisa berkembang dengan baik, terutama pada lesi-lesi yang dengan kalsifikasi yang berat ya. Namun persoalannya pada MSCT ini terdapat apa yang disebut blooming effects. Nah, blooming effect ini yang tidak bisa secara sempurna untuk menyatakan bahwa apakah suatu tindakan pada lesi kalsifikasi tersebut didapat menggunakan, apakah perlu menggunakan rotablasi atau orbital atherectomy ya. Nah, saat ini juga terdapat apa yang disebut kemajuan dari teknologi, yaitu photo counting CCTA. Photo counting CCTA ini tidak lagi menggunakan sinar gamma, tapi menggunakan foton. Dan kelebihan resolusi spasialnya juga luar biasa ya, karena mirip angiografi dengan 0,2 mm ya. Dan kemudian dapat mengevaluasi stent dengan baik dan juga kalsifikasi dapat didelineate, dapat dengan lebih jelas kita lihat bahkan lokasi dari kalsifikasi, eccentricity dari kalsifikasi. Ini teknologi yang sekarang ini kita bisa dapatkan di dalam proses identifikasi atau diagnosis kalsifikasi. Dan yang sering kita dengar bersama adalah penggunaan iFuse dan penggunaan OCT. Kita tahu iFuse berbasiskan sounds ya, dan OCT berbasiskan cahaya. Dia merefleksi pada iFuse, dia merefleksi kalsium kristal sehingga kalau kita mengidentifikasi, mendiagnosis kalsium, terdapat hyperechoic dengan acoustic shadow. Namun pada iFuse kita tidak dapat mengukur ketebalan dari kalsifikasi tersebut. Sementara kalau melalui OCT kita bisa mengukur ketebalannya karena dia mampu apa yang disebut, kita dapat mengetahui tebal ini karena dia delineated border ya. Dengan signal poor region ini dan delineated border kita bisa mengetahui besarnya tebalnya kalsium. Cahaya dari OCT ini mampu mempenetrasi kalsium kristal. Sayangnya OCT ini memerlukan blood clearing sehingga sedikit memerlukan tambahan kerja ya. OCT yang terbaru dapat dengan power artificial intelligence Ultron 2.0 itu mampu menghitung sudut angle dari kalsiumnya ini yang juga akan dapat membantu kita menentukan volume dari kalsium dan bahkan juga thickness dari kalsium ini secara langsung. Jadi tanpa kita ukur dia sudah akan memberitahu kepada kita. Ini tentu akan memudahkan kita di dalam strategize untuk tindakan intervensi pada lesi kalsifikasi. Dan pada diagnosis kalsifikasi, sebagaimana disampaikan bahwa kita tidak cukup hanya mengidentifikasi kalsifikasi, adanya kalsifikasi, namun juga mengidentifikasi eccentricity, pattern-nya. Pattern di sini maksudnya adalah eccentricity, yaitu arc calcium arc ya sudut degree kuadran dari kalsium ya, apakah dia eksentrik, konsentrik atau kalsium ring 360 derajat. Nah, juga kedalamannya distan dari lumen profile. Ada yang kalsium dengan protrusi, yaitu yang kita sebut nodul, dan kemudian ada yang superficial, ada yang deep ya. Ini adalah deep kalsium, sorry. Ini kemudian ini superficial kalsium. Ini juga kita bisa menentukan dalam pattern kalsifikasi itu adalah kalsifikasi yang tebal dan tipis, dan juga panjangnya, apakah vokal ataukah panjang dari kalsifikasi ini. Nah, ini adalah arc dari kalsifikasi, kita ini menyebutnya sebagai eksentrik dan ini adalah konsentrik. Dan CCTA juga bisa, dengan foton tadi, kita bisa juga akan menentukan bahwa kalsifikasi eccentricity dan concentricity dari kalsifikasi. Jadi kalau kita dapat mendapatkan data dari CCTA juga akan bermanfaat untuk kita. Dan ini depth dari kalsifikasi ya, ini adalah deep calcification dan ini adalah superficial calcification. Pada kasus seperti ini biasa kita tidak melakukan tindakan aterektomi walaupun kita melihat kalsifikasi di sini, dan tapi pada superficial yang semacam ini biasa kita akan menggunakan aterektomi. Dan juga di dalam depth dari kalsifikasi ini saat ini yang tengah berkembang adalah kita mendeteksi adanya calcified nodule yang terdiri dari dua tipe, yaitu eruptive calcified nodule dan non-eruptive calcified nodule. Eruptive calcified nodule biasanya memungkinkan kita crack dengan balun tanpa harus rotablasi. Tetapi pada kalsium nodule yang non-eruptive biasanya keras dan ini memerlukan tindakan aterektomi. Penting juga untuk mengetahui panjang dari kalsium, dan di antara kalsium tersebut ada lipidik ya, karena kalau kita mau menentukan aterektomi, kita harus menentukan fokus kepada lesi kalsifikasi tersebut. Jadi walaupun di depannya ada lesi yang berat, tapi kalau lesi tersebut bukan lesi kalsifikasi, kita tidak melakukan aterektomi pada tempat tersebut. Kita lebarkan dulu dengan balun, baru kita fokus kepada lesi yang kalsifikasi. Kadang-kadang ada multiple, ada di tempat di sini kalsifikasi, di tempat di sini kalsifikasi berat, maka kita melakukan aterektomi di depan, di atas, ya di proksimal, dan kemudian kita melakukan di distal tanpa harus melakukan tindakan secara menyeluruh. Karena kalau tindakan secara aterektomi secara menyeluruh demikian bisa potensi nanti akan terjadi slow flow. Jadi kita harus mengetahui panjang dari kalsium, lokasi kalsium, dan juga distribusi dari kalsium. Dan ini adalah kalsium thickness, bisa menggunakan OCT, dan IFUS tidak mampu untuk mendeteksi kalsium. Ya, namun OCT finding, ini kalsium thickness berdasarkan OCT, IFUS finding based on OCT maximum calcium thickness, OCT dengan calcium thickness kurang dari 0,5 itu biasanya IFUS memperlihatkan smooth surface dan reverberasi. Jadi kalau kita dapatkan ini, kemungkinan bahwa kalau berdasarkan IFUS, karena IFUS tidak mampu untuk menentukan tebalnya, nah ini adalah studi yang berusaha untuk mencoba membandingkan dengan OCT, dan dia mengidentifikasi kalau smooth surface dan reverberasi, maka kemungkinan bahwa kalsium thickness-nya adalah kurang dari 0,5. Nah, kalau yang lebih dari 1 biasanya irregular surface without reverberation pada IFUS ya. Jadi kalau kita mendapatkan OCT demikian, IFUS demikian, biasanya OCT-nya tebal ya, dihitung kalsifikasinya tebal. Dan ini adalah memperlihatkan perbandingan pada lesi yang sama dengan menggunakan IFUS dan OCT. Kita lihat ada hal yang menarik ya, tentu saja ini superficial ya, namun ini deep dan ini adalah fibrotic. Ini memperlihatkan deep kalsifikasi. Yang di sini menarik ya, kalau kita mendapatkan lesi hyperechoic di sini pada IFUS, tapi kita bisa melihat tissue behind di sini, kemungkinan bahwa ini bukan kalsifikasi. Namun dan bisa jadi kalaupun ada kalsifikasi, dia adalah tipis kalsifikasi. Dan ini ternyata bukan ya, bukan kalsifikasi, sehingga kita tidak memerlukan tindakan yang agresif ya. Di sini memang ada kalsifikasi. Nah, ini adalah kalsium nodul, ini adalah eruptif kalsium nodul. Nah, peranan coronary imaging dalam menentukan strategi calcium modification ini nanti akan Dr. Keke akan menjelaskan bagaimana tindakan menggunakan device tersebut. Jadi kita hanya akan menentukan melalui diagnosis kalsifikasi apakah lesi kalsifikasi tersebut memerlukan aterektomi atau tidak. Nah, kalau dari OCT kita dapat memprediksi thickness-nya. Jadi kalau dia tebal 0,67, kita akan sulit untuk mengcrack dengan menggunakan balun, sehingga kita memerlukan aterektomi. Jadi di dalam mendiagnosis itu penting untuk menentukan ketebalan dari kalsium tersebut. Jangan dicoba, karena kalau dicoba nanti ini studi sudah memperlihatkan bahwa Anda akan kesulitan untuk mengatasi hal tersebut. Dan ini CCTA juga dapat memprediksi dengan mean density lebih dari 637 Hounsfield secara cross-seksional dapat memprediksi kebutuhan aterektomi dalam PCI. Jadi dengan data-data CCTA kita juga dapat menyiapkan, memplanningkan untuk tindakan yang lebih agresif. Nah, ini kita di dalam menggunakan intracoronary imaging maupun CCTA terdapat skor-skor yang menentukan apakah kita memerlukan tindakan aterektomi atau tidak agar stent bisa ekspansi ya. Ini OCT yang kita bisa mendapatkan 4 poin di sini ya. Dan ini IFUS score yang kemudian kalau di OCT 3 atau 4 kita memerlukan aterektomi. Kalau ini 2 lebih, kita sudah harus menggunakan aterektomi pada IFUS ya. Dan ini grade daripada CCTA yang menentukan lesi kalsifikasi, dan ini memang data untuk hal CCTA ini lebih terbatas. Dan lebih lanjut, walaupun lesi kalsifikasinya itu terlihat tidak konsentrik, namun dia eksentrik dan di depannya adalah bifurkasio, maka kita perlu untuk mengatasinya dengan lebih agresif. Bila tidak, maka side branch yang di depan lesi kalsifikasi itu akan menyebabkan kompromis dari side branch tersebut ya. Nah, 3D calcium map dengan menggunakan CCTA ini juga dapat untuk memberikan informasi tentang posisi pada kalsium pada bifurcation. Ini memang teknologi yang lebih mutakhir ya, sehingga kita dapat memplanningkan dengan baik bagaimana kita mengatasi masalah kalsifikasi. Nah, ini adalah prosedur risk dalam kalsifikasi. Kita tahu ini adalah hematoma setelah aterektomi. Nah, ini setelah aterektomi terdapat hematoma. Ini kita lihat ada hematoma. Kita harus melakukan tindakan perbaikan. Jangan dilakukan tindakan aterektomi berikutnya ya. Dan kemudian ini no flow after aterektomi ya. Dan kemudian ini adalah perforasi. Penggunaan intracoronary imaging dapat mendiagnosis dan juga mengantisipasi dari komplikasi yang terjadi akibat tindakan agresif yang kita lakukan. Dan ini assessment procedural risk, kalau kita mendapatkan intracoronary imaging data, kita bisa melihat apakah wire-nya itu berada di lesi kalsifikasi atau di tempat yang sehat. Kalau wire di tempat yang sehat ya, maka kalau kita melakukan aterektomi bisa melukai daripada vessel tersebut dan bisa perforasi ya. Kalau yang seperti ini, maka ini disebut favorable wire bias, maka akan mampu untuk melakukan debulking dengan baik. Sayangnya CT angio kita tidak dapat menggunakannya intraprosedur. Jadi assessment procedural risk ini juga terkait dengan wire bias pada eccentric kalsifikasi vessel dan lumen diameter, dan kita juga menentukan nanti burst size-nya, longitudinal distribusinya. Nah, ini penting sekali data-data ini di dalam mendiagnosis kalsifikasi. Nah, ini data dari IFUS yang didapatkan Dr. Sumit Suji yang memperlihatkan semua hasil IFUS yang seperti ini ruptur setelah stenting. Jadi karena itu dengan pemahaman-pemahaman lebih lanjut terhadap imaging pada kalsifikasi, kita dapat memanfaatkan untuk tindakan yang lebih aman. Kemudian bagaimana yang disebut dengan successful calcium modification? Dia adalah, ini kita melihat ada 4 ya, calcium fracture, reverberations pada IFUS, dan calcium volume reduction dan lumen enlargement. Sayangnya CCTA tidak bisa kita gunakan untuk hal tersebut. Ya, ini adalah contoh-contoh bahwa bagaimana crack tersebut. Dan apakah penting untuk menentukan adanya fracture tersebut? Jadi kalau kita melakukan tindakan atherectomy, kita juga harus menentukan apakah tindakan kita itu berhasil atau tidak. Ini memperlihatkan bahwa kalau kita mendapatkan calcium fracture, maka MSA-nya akan lebih baik dibanding tanpa calcium fracture ya. Dan juga kita memperlihatkan hasil yang ada ini penting untuk kita ketahui bersama bagaimana memprediksi stent expansion dengan mendokumentasikan calcium fracture. Dan ini adalah contoh yang bagus untuk menentukan apakah kalsium tersebut telah fracture atau tidak ya. Jadi ini kita melihat baik dari OCT, ini reverberasi, fracture ya. Ini fracture ya dari OCT. Dan ini penting untuk kita ketahui bahwa ini lesi eksentrik dan setelah dikembangkan terdapat fracture ya, maka kita bisa mengembangkan stent tersebut walaupun memang belum sempurna. Seandainya ini bisa dilakukan tindakan ablasi mungkin akan lebih baik. Demikian pula ini konsentrik dengan adanya rupture, maka dia stent bisa berkembang dengan baik. Nah, ini setelah tindakan post balloon ya, ternyata tidak mendapatkan fracture, maka tidak bisa untuk dilakukan tindakan berikutnya ya. Jadi ini penting kalau kita melakukan balun dan kemudian balun tidak mengembang, dan juga harus diperhatikan pengembangan balun. Kadang-kadang kelihatan balun mengembang tapi hanya pada sisi yang healthy vessel. Nah, ini adalah evaluasi coronary imaging pada optimalisasi. Kita tahu bahwa intracoronary imaging dapat memberikan informasi juga bahwa apakah tindakan kita sudah optimal. Akhirnya, dengan kemajuan teknologi coronary imaging dapat mengarahkan identifikasi coronary calcium morphology dan memperbaiki treatment strategi ya. Dan comprehensive coronary imaging assessment adalah penting dalam planning prosedur, assessment resiko, strategi modifikasi, dan juga optimalisasi. Demikian, terima kasih.
Ya, terima kasih Dr. Fauzi untuk lecture-nya yang ekstensif tentang intravascular imaging pada coronary calcified lesion. And the next speaker will be Dr. Yeo Khung Keong from National Heart Center, Singapore. Now, Dr. Yeo is the Chief Executive Officer and Senior Consultant, Department of Cardiology, National Heart Center, Singapore, and then Deputy Group Chief Medical Informatic Officer for Research in SingHealth, and then Academic Chair for the SingHealth, Duke, and National University of Singapore Cardiovascular Sciences Academic Clinical Program, and also past chair of the Scientific Advisory Board for the Asian Pacific Society of Cardiology. Okay, so Dr. Yeo, the time is yours for next 20 minutes.
Thank you, Dr. Rifqi, and thank you both Dr. Rifqi and Dr. Fauzi for inviting me to speak on this. Pardon my voice, is just recovering from a cold. Can you see my slides? Okay.
Yes.
Yeah.
But not yet full
Oh, not full screen.
Yeah, not full screen yet.
How about this?
Okay, yeah, it's okay. Now it's okay.
Yeah, so I listened with to Dr. Fauzi's a very impressive talk, and I just want to maybe touch on the treatment of calcified vessels in 2024. These are my disclosures. I think we have already heard from Dr. Fauzi that calcium is a real unpleasant thing to have in the coronary arteries, and there are risks, including stent under expansion, the risk of stent dislodgement, and procedures become very difficult when you have tortuosity on top of calcification. One of the major risks is that of perforation, and we know from the data that you saw earlier from Dr. Fauzi's presentation, some of the complexity and difficulties when we have calcified arteries, and this is just one such slide showing that as a vessel becomes more calcified, the event rate in terms of complications go up. And this is a classical example of a rotor regret in which after stenting, you have a severely underexpanded area that no amount of non-compliant balloon dilatation can fix. And if you try too hard, the vessel will rupture on the opposite side. Now, the SCAI, the Society for Cardiac Coronary Angiography and Intervention, had these guidelines out in their journal. And I think you have already seen some of the slides. We have discussed early on a very nice discussion by Dr. Fauzi on some of the imaging considerations. And I think this is important because it allows us to know what goes on in our minds when we deal with a calcified lesion. This flowchart shows the treatment protocol, and I think it's worth going through this, if only because I don't always follow it, and I'll explain why. So at the beginning is if you see some angiographic evidence of calcified disease, or if you know ahead of time on CT scan there is calcified disease, you may want to have intravascular imaging to evaluate for such disease. And if the criteria for calcium modification is met, then you may consider some form of plug modification, either with rotablator or other tools. And if you are able to do it, or if you don't have this other technologies available, you can consider balloon angioplasty. But what I think is very important for this particular flowchart is that it is the middle where if the imaging criteria are not met and you have a balloon and you're still unable to deliver, you may still have to go to rotational atherectomy or some other form of atherectomy. Now, I put up this slide because I want to say that there are different criteria we look at when we look at good food. This is French cuisine. I don't know about you, but I maybe don't like French cuisine that much. It's too fancy. I don't feel full and it takes too long. But it is very nice and very fancy. And you can get a lot of Michelin stars. I prefer our Southeast Asian cuisine, whether it is satay or laksa or chicken rice. And there are stores with Michelin stars with chicken rice. And so I have adapted some realities on the ground to my practice. And although people say that Singapore is a rich country, you can't believe how much our ministry is squeezing us to make sure that we deliver cost-effective care. So what are the realities on the ground in 2024? Number one, time. We have limited time. There are always patients waiting for their cath lab slot. Cost is expensive. The shockwave in Singapore is about 3,500 to 4,000 Singapore dollars. Equipment may or may not be available. Training and familiarity remains important. Not all of us are comfortable with CSI, for example. And even for those who are comfortable with rotational atherectomy, the nurses will also need to be familiar for them to adequately support you. And of course, the issue of experience, which is very important. I can see from the cases that are shown that many of our operators here in Indonesia and Southeast Asia have lots of experience. So I think that's important to bear in mind. What are the guiding rules that I have adopted to my practice? It used to be that imaging was not there, but you have heard Fauzi's very, very nice talk explaining where intravascular imaging may be helpful. But I want to begin by anticipation. If I have an elderly patient, somebody aged more than 80 years old, somebody with chronic kidney disease or long-standing diabetes, I anticipate calcium. And I think if you see calcium, you should plan on possible management strategies as well as prepare rescue equipment, including the presence of covered stents. And as you heard, where appropriate, use intravascular imaging to assess the extent of calcification and to optimize results. I want to say that I don't use it every case because for certain conditions, I have enough information to get a good result, and therefore I don't want to use it if it doesn't change my management. Number 4 is really important. I think one should keep to your preferred strategy and your preferred toolbox. Because calcification is fraught with complications, it is quite important not to try new things if you have not prepared adequately. So for my practice, when I learned from my mentor, it was quite a straightforward instruction he gave me. He said that just do the same thing the same way as long as it's the same kind of problem. It helps to reduce uncertainty. Of course, if you learn something different and it's better, such as the presence of the use of intravascular imaging, then you should use it. And in the setting of calcific disease, if you think about it, you probably should do it. It's probably better to prepare the lesion first than to struggle later on. Now, this slide here shows some of the tools that you have. You have already heard about some of them earlier on. They all have pros and cons, and not all of them are available in all practices. For example, we don't have laser here in Singapore. We used to, and I've used it before in the United States when I was in training, where you use a sort of laser plasty to explode the vessel, but it's a bit tricky, and we don't have it here. And similarly, some places may not have a little plastic balloon, and the OPN, as I understand, is not always available in every country in Southeast Asia. So these different tools would have to inform your practice, and I think we can go through some of this later on. What are the tools that I have in my toolbox? And without going through all the different tools that you saw in the preceding slides, let me share with you my toolbox. And I think this is particularly relevant because for a tool like rotational atherectomy, it has been in the market for a long time, and many of you are experienced operators of the technology. Of course, if you are familiar with CSI orbital atherectomy, it is also a very powerful adjunctive tool and can be considered. In my practice, I tend to keep to rotational atherectomy and only use CSI when it is a very specific thick calcium or nodular calcium where I want to ablate sideways. You should have access to special balloons such as angioscope, OPN, and to a lesser degree, I also use Wolverine and Scoreflex NC. Because of the availability of angioscope, I've begun to use Scoreflex NC a lot more, especially the trio, which I will show later on. And of course, shockwave. Now, shockwave's penetration in Southeast Asia is highly variable. We have it in Singapore for several years now, but I know that there are Chinese companies that have similar technology. Some of them use laser in their technology to create a shockwave. Others use other scientific principles to create a shockwave. But be that as it may, I think the competition will be good because you bring down the price of the technology, and that means better access to our patients, for our patients. So I'm going to talk about rotational atherectomy. I think it is an absolutely essential tool, and in the setting of complex coronary interventions, especially where there's highly calcified vessels, I think it is, we need to have it in our armamentarium. As you know, it's a diamond tip drill, and it can drill at about 150K to 200 over K revolutions per minute. It is considered a high-risk procedure, and I would do it with a lot of care, and as I'm sure you saw from the earlier slide, there's a good risk of perforation and other complications. Some important facts about key components of the rotor technology. One is the type of wire you choose. In my practice, I've only used the floppy wire maybe less than 5 times in my entire practice over the last, I don't know, 20 years. And that's because if you look at it, the main difference is only in the proximal, maybe between 13 centimeters for the floppy wire and 5 millimeters in the extra support wire. Only that difference in terms of what is stiff and what is not. The reason why I like the extra support is that it forces wire bias. I want the wire bias, but of course that comes at a price. And in cases where the vessel is very tortuous, you may choose to use a floppy wire, but that also comes at a price of potential kinking the wire and uh, breaking the wire in the coronary artery. Now, the other thing is, of course, the tip of the wire is 0.014 of an inch, and the body of the wire is 0.09 of an inch. The Viper wire for CSI is 0.012 of an inch, which makes the two incompatible. So important to be aware of these differences. The other major thing to be aware of is that you need to select the guide for the appropriate burr size. And nowadays, with some of the more thinner guides, you may be able to squeeze in a bigger burr into a smaller guide, but these are the recommended guide and burr sizes. And with an 8 French guide, you pretty much can do up to 2.15 millimeter burr, and by anything more than that, you need a bigger guide. The other thing that is important is the concept of differential cutting. So if you believe in the theory, if you have a very pliant tissue, soft, the differential cutting will make it safe such that the blade, or rather in this case, the diamond tip will not cut into the thing. Kind of like you can press against your hand with a blade and it doesn't cut, whereas if it's a hard item, it will cut. So this differential cutting concept is important. What are some of the key relative contraindications for rotablator? I put them here. Severe angulation. This, I think, is a major worry for me whenever I do rotablator. But again, depending on the wire you use and your experience, you might be able to navigate this. The presence of thrombus or significant dissection. And significant dissection, I will spend a bit more talking about it in a while, but the other complications, the other risks include the use of rotablator in vein grafts or internal mammary artery grafts. I've only seen one done successfully, and even then the vessel was terribly dissected. Severe hemodynamic instability, somebody in cardiogenic shock doing rotablator, probably not the best idea. And of course, you need a good team and operator experience. Some other key things in terms of preparation. You want to get coronary vasodilators present with pre-treatment with either verapamil, adenosine or nitroprusside or GTN. And of course, the patients need to be adequately treated with antiplatelet therapy. Some of the complications you saw early on, no reflow, slow flow, perforation, heart block, burr entrapment, or wire fracture have all occurred in my practice. They are never pleasant to deal with, but you need to be prepared for them. Now, I mentioned the CSI. This is the Diamondback 360 orbital atherectomy. What it has in the middle, if you can see the picture in the bottom, is a off-center or eccentrically placed burr which drills sideways. The idea is that at higher speeds it would swing outside more and therefore ablate the sides even more. The device is easy to use. The main problem, or rather the main challenges, are that number one, if you have a very tight lesion and the device cannot get through it, then it will not do any atherectomy for you. You will have to go through with a rotablator first. Number two is that it takes a long time. So for me, I'm a bit impatient, so I don't like to use the orbital primarily because it takes too long. But it has one major advantage, two major advantages. One is that it can ablate around. That means that for calcium nodules or areas where the wire bias is not in your favor, you can use this technology. And number two, you can ablate on the way back. So watermelon seeding is much less uncommon compared to the rotablator. Now, turning my attention to balloons, this is the angioscope. The angioscope is actually a semi-compliant nylon balloon, but it has a scoring element. This is a sort of a double helix nitinol wire wrapped around the balloon. And when the balloon expands, it bites into the lesion. In my practice, I found it very useful for stretching and breaking non-compliant areas because the force is focused onto those parts of the vessel that don't expand. And we generally recommend slow inflation, and a size matching is usually slightly less than the vessel reference diameter, but you can go very high pressure, and you can help do it repeatedly to open up the lesion. The Wolverine, I think, is familiar. This is from Boston Scientific, and it has a recent iteration, and this is now a lot better. Previously was just known as the cutting balloon. It is now a lot more deliverable with a better crossing profile. Similar to the previous iterations of the Wolverine, it has 3 blades that help cut. What is important is to inflate and deflate the balloon slowly so that the wires wrap themselves up appropriately. The Scoreflex is just another balloon which has a similar concept to the angioscope, except that it uses a nitinol wire that is integrated to the balloon as additional cutting elements. And you can see here, the new Scoreflex Trio has 2 integral wires, which together with the guide wire forms 3 cutting elements. It's also supposed to be a lot more deliverable. They will always claim this, but I think it depends on your personal experience as to how these different crossing profiles affect your practice. There are other similar technologies, the NSE Alpha, the chocolate, the Aperta, etc. But I think for practical purposes, we can't have everything, so I stick to what I'm familiar with. Now, the OPN is a very important toolkit. This is a high pressure balloon, super high pressure balloon, and it gets to be super high pressure because it has 2 layers to the balloon. Now, the main problem with this is that it's a very scary balloon. I'm more scared of this than I am of rotablator, because if you have a very resistant lesion and you open it, if the vessel gives way, it doesn't give way where the calcium is. It gives way where the calcium is opposite of. That, in other words, in a near normal vessel. You can go up to 40 atmospheres, and typically there's a sudden give, and usually I have a covered stand nearby. I use this only rarely. It's a very scary thing for me because you don't have control over whether the lesion will break in the calcified area. Now, coming to specialty balloons, the shockwave is indeed a revolutionary technology. And as you know, it works by having a spark, kind of like a spark plug inside a balloon. And the spark plug, in the presence of saline and contrast, generates a pulse field which breaks calcium up, and this creates a force of about 50 atmospheres. And the original research papers were published several years ago, and I only want to highlight one thing, and that is the technology is very safe. If you look at just the complications from IVL, they are very, very low, at most dissection, maybe a bit of slow flow, but no complication doesn't mean that there will never be any complication, but just want to highlight that it's a very safe technology. So in the last couple of minutes, I want to highlight how I use these technologies to treat my patients. So this is a 60-year-old man, triple vessel disease, rejected by surgery, EF is impaired. I think you can appreciate the Prox LED as having very severe calcified disease on angiography alone. So standard rotablator 1.5. Now this was very early when shockwave was first available. We use an NC balloon. You can see the residual waste on the right side of the screen. And this is an NC balloon, and it still can't expand. And shows the residual area. And now you can appreciate that calcium has really, really severe circumferential. So this is a shock wave, a 3-5 shock wave, and you can see the balloon progressively expanding. And finally, on the right side of the screen, with the last few shocks, the vessel opening up nicely. And this is a after shock wave. I completed the treatment with angioscope, 3.5, and now you can see full expansion of the vessel, finally a stent, and these are the final results. So our group has published some data on rotor trip C. And there was another group, I think, out from Europe that also published similarly. This is on the bottom right, is from the Journal of APSC, where we publish our data. So I'm sharing a bit of our data. Our procedural success was about 90%. And you can see that most times you just need one shockwave balloon. And the number of burrs used vary, but most have only one burr. Further information about the characteristics of the balloon, the size, and the number of shocks is shown. The results from our data show that because these are very high-risk, complex patients, we do have only about 90% procedural success. But this is similar to the European experience, where they have about 93% procedural success. I want to end off with just this case. This is a patient that I think most of us would agree is not a good patient for PCI. The right is a CTO. You can appreciate the calcium. The EF is 15%. But with rotablator and shockwave, these are the results that we could achieve despite this long, diffuse, complex anatomy. And we can see the before and after images. Oops, sorry, too fast. Well, I think you get a bit of the. So this is before and after. So I want to say that these are all complications that are possible. We don't have time, but if we have time, I'll be happy to show you a burr burrito complication. I think the rest of the complications most of you are familiar with. A burr burrito happens when you have a lot of dissection, and usually only after a lot of balloon angioplasty. And then after that, you say, okay, fine, it doesn't work. Let's put in a rotablator. And then you can do a burr burrito where there is wrapping of the intima around the burr. And that is usually a disaster. And the protection against these complications is listed first for no reflow, slow flow, intracoronary agents, perforation covered stents, trap burr burritos, good technique. If the burr separates from the wire, the main thing to do is pull, but you have to be careful about dissecting the left main. And of course, heart block nowadays is much less common, but you might need a temporary pacemaker. So this, again, is the recommendation from the Sky group. I think this is in an ideal world, but we probably have to adapt based on the reasons I gave earlier on. So my practice, I use a very gentle guide, a Judkins guide. I will wire with a BMW or Fielder wire, exchange for rotor extra support. If need be, I will wire directly. I might need a Corsair Pro if it's very tight. Microcatheters can sometimes break. I will escalate from a 1.25. And if there is a waist, a narrowing after balloon angioplasty, I will escalate to shockwave, followed by angiosculp or NC Scoreflex. OPN is last resort. And again, like what Dr. Fauzi says, you need to learn how to use imaging appropriately. For me, I do use it if it's left main or if I'm sure what is happening, but for me, I don't routinely use it. So to summarize, anticipate the problem. If you see calcium, plan accordingly and prepare rescue. Where appropriate, use intravascular imaging to optimize. Keep to your preferred strategy and preferred toolbox. Consider rotor C because it saves you the effort of upsizing. And if you think about it, it is probably good that you should do it. Thank you very much for your attention.
Thank you very much, Dr. Yeo, for your very excellent lecture. And then we will proceed to the case, and then we will discuss the case regarding the information from two lecturers, and then we will ask the panelists to give a comment and as well as the presenters. Please, Dr. Tami, present your case.
Thank you, Dr. Rifqi. Good afternoon to Dr. Rifqi, Dr. Fauzi, and Dr. Yeo, and to all panelists. Let me share my screen first. Can you see my slide?
No, yes.
Okay, great.
Okay. Thank you. It's a pleasure to share with you our case entitled with How Do I Break the Recalcitrant Calcified Lesion? My name is Aprilianasary Utami and you can call me by Tami. I work as cardiologist interventionist at Sumedang District Hospital. I have no potential conflict of interest. I'm going to share this case. A 74-year-old male presented with chronic coronary syndrome. Angina occurred this past 6 months despite optimal medical therapy. Patients already underwent PCI 2 years ago caused by ACS at RCA. Syntax score was 33 and Neuro score 2 was 0.87%. Uncontrolled hypertension remains the main risk factor since patient already quit smoking after first PCI. Echo showed hypokinetic anterior wall with EF for 45% and renal function was within normal limit. The RCA angio, we can see a mild mid-stenosis with a patent stent at proximal part. This is the left angio. We can see the true bifurcation lesion with radiopacities and tram tract calcification can be seen. Severe stenosis at distal left main extended to mid-LAD and small caliber CX with ostial to proximal mild stenosis was seen. Initially, we were going to do an IVUS study, but IVUS catheter cannot pass the lesion. So we did initial pre-dilatation using 2.0 by 15 millimeter semi-compliance balloon, followed by 2.5 by 15 millimeter Scoreflex balloon. Then I first showed a distal reference of 8.67 millimeter. We can see some acoustic shadow presence in cerebral segment, which indicate calcification. There's also concentric calcification at mid and proximal part. Eccentric calcification presence. There's a subtle and diagonal versus within normal limit. There's also another eccentric calcification at proximal part, followed by concentric calcification. There was also calcification just opposite of the CX, followed by nodular calcification at left main. So we have multiple shape of calcification in this patient. Indirect visualization tells us no significant stenosis at circ with 90-degree angle. So what would you do?
Thank you, Dr. Utami. Very nice, very challenging case. It's not nice, actually, very challenging case. Yeah, Dr. Rifqi.
Yeah, sorry. I just I forgot. I'm mute. Okay. We stop here and then please, panelists, any comment?
Okay.
From the panelists?
Yeah.
Yeah.
Can I ask what size catheter did you use? Is it 7 French, if I'm not mistaken?
Yes, 7.
Yes. Okay. So in my my practice, and I'm more familiar with the orbital atherectomy. Usually, if concerned with the left main, then I would use the intra-aortic balloon pump just in case that we have the hemodynamic problem. And second thing is that I use as you do, I use the 7 French just in case that because it's left main and we have the circumflex to save an LAD. And in this case, luckily you manage opening the vessel, the tight lesions with the balloon. And yes, after you can dilate with a balloon, then I usually do orbital atherectomy and use the Scoreflex balloon, and afterwards I use the putting the drug-eluting stent and finish and evaluate also again with the intravascular imaging. I think that is what I would do in this case.
Okay, thank you, Dr. Yahya. Any other opinion from panelists?
Yeah. Hello.
Yes, yeah,
Yeah.
Dr.
Thank
Yasin.
you,
Yeah.
Dr. Rifqi. Very challenging case by Dr. Tami. So first of all, I have my share for doing a calcified case. As Dr. Rio explained earlier, fortunately, I've had experience on each one you said, like stent dislodge, I have it, I've experienced it, underexpanded stent, I've had it, perforation and etc. I've had it. So calcification is very challenging and it is very it's okay if you stop, especially for us the junior or for just completed our fellowship. Please do not do this like at apa CAT standby PCI. So it's better if you just stop and then you can plan it better. So for the presentation itself, is it ad hoc or is it stage PCI?
Stage PCI.
Stage. So, and the next one, I think you already done exactly as it should be, like very thorough, very good stage by stage. But if I may ask, why do you choose the first one as to do a scoring balloon first? Why not do a small like NC balloon or semi-compliant balloon just to pass the IVUS, and then after that, you can use directly cutting or maybe a scoring if it is needed.
Yeah, we did initially we did by semi-compliance balloon, but the balloon did not expand well, so we continue with scoring balloon, only small size.
And do you have the cutting at that time in your toolbox?
I have Scoreflex and NSC Aperta at that time.
Oh, so if you had it, would you choose a more specialty balloon like Wolverine cutting balloon, or you would still prefer to do the scoring balloon? Like Dr. Yeo said that the scoring has a more easily passable to push around. Do you still want to use the scoring, or you want to change to cutting if you had it?
I think I will stick for the scoring for the first try because I was just about to open the passage for IVUS first because I don't want to ruin the vessel for the next OAS. So probably I'll just stick with scoring balloon.
Okay, understandable. Thank you.
Okay, Dr. Baharudin.
Yes, thanks, Doctor. And Dr. Tami, yeah, I would suggest one thing that when you did IVUS, the longitudinal picture should be shown so we can calculate how long the calcification. And the second is when you did the predilation using 2.5 millimeter NC scoring balloon, did the balloons expanded well in all the lesion?
Only a few. Only a
Uh,
few. Yeah.
so not well expanded in
Yes.
some parts.
Yes.
Okay. Yeah, so meaning that calcification may not successfully by using a scoring balloon.
Yes, true.
Yeah.
Yes.
And then the third, regarding the IFU's imaging, we know that we need what we call rotablation or other modality if there is some requirement from IFU's imaging. First, if there is more than 270 degree calcification with the length if more than 5 millimeter. In this case, we cannot make sure because you didn't calculate the lengths by showing the longitudinal view of IFUs. And second, if I think there is no napkin ring in this case, almost maybe close to 330 in one view. But unfortunately, there is one calcium nodule, I think in the proximal, close to the ostial of the LED. There is in frame at frame of 1113, 1113. I think there is some calcium nodule. So in this case, because the nodule, the calcification of nodule calcification, we may need rotablation for this case. Thanks, Doctor.
Okay, Dr. Tami, please.
No, Dr. Rifqi, Dr. KK is going to comment.
Okay.
Oh,
Yeah, please. Dr.
yeah,
KK.
I think thanks. This is a really tough case. I guess I just have a quick comment about, what I would worry about. My main worry is that you have used the Scoreflex and that intentionally will dissect a cut into the vessel. So that does create a bit of risk. If the lesion is not terribly dissected, I think one can still consider rotational atherectomy. But for orbital, I think because of the nature of the technology, you do have to be very careful that it would not get the burrito. I'm not sure what the right word is, but the burrito effect where you wrap the lesion. So for me, I would say that the moment you can't cross with IVUS, I would just go to rotablator because once you balloon, you expose a little bit of risk for subsequent options. Thanks, over.
Okay, thank you very much, Dr. Yeo. Dr. Fauzi, any comment?
Yeah, really, this is a very tough case. The first planning is whether the patient would love to have KBH or not, because the distal runoff is very good. So if a patient really reviews about it, because the syntax score is 33, is a very complex coronary anatomy. So if the patient refuses to have a KBH, then we try to handle the very diffuse calcified lesions. In this particular case, Dr. Tami demonstrated how he handled with try to use intracoronary imaging to identify the complexity of the calcified lesion. But unfortunately, she was unable to cross the lesion using intracoronary imaging. So trying to dilate, and this kind situation, it is important to pay attention to what KK said, that if you are using a balloon before atherectomy, try to use be cautious in using it, because if there is a dissection, it's going to be a problem. In this case, fortunately, there is some bit dissection in plaque, and then IFUS demonstrated multiple shape of calcifications. There is a eccentric calcification, there is concentric calcification, there is multiple nodule calcification, there is calcification opposite of the circumflex, which we have to handle before putting the stent. In this case, from the IFUS finding, it is okay if you are using rotational atherectomy or orbital atherectomy. The important, if you are using orbital rotational atherectomy, use in high speed to reduce the burr going to the healthy vessel in the eccentric. And if you are using orbital atherectomy, use in a slow speed, and then interrogate again using intracoronary lesion, which is IFOS, to understand well how it behaves after rotational atherectomy or orbital atherectomy. In this eccentric calcification at the left main, which is very bulky calcified lesion, we have to debulk more, because otherwise this going to compromise to the circumflex. In this case, if you are using a rotational atherectomy, I think it maybe we need not just one burr size, but maybe we need upsize burr, especially in the left main. We are using maybe need 2 mm burr to ablate the eccentric huge calcified there. Of course, if you are having IVL, it's less than you are using to upsize the burr. If after using rotational atherectomy, you use IVL, it's going to be great. But if you are not have a IVL, maybe you should upsize the burr size. That's why in this case, orbital atherectomy play an important role. It's just one size, and then you can use maybe high speed for just the left main part. Is going to be debug more. That's my point, Dr. Rifqi. Thank you.
Yeah, Dr. Fauzi. Regarding Dr. Barudin's comment that the score of calcification may be less than 2 because there are no real napkin rings, and then no 270 calcification with the length more than 5 millimeters, and then only like a calcified nodule. What do you think about the? Is there any?
Yeah, in my opinion, it was a concentric calcification. It is more than it is very heavy and calcified lesions. We were unable to. It is quite difficult to deal without using atherectomy device for such a severe calcification lesion. There is, as I said before, there is a multiple shape. There is eccentric, concentric, and then multiple calcium nodule in every place. In this, in the distal part of the LED, there is less calcifications. That's why maybe the calcified the strategy to atherectomy the mid part to the left mid. Yes.
Okay. Thank you very much, Dr. Fauzi. Okay. Next. Now, what have you been done, Dr. Tami? Then let's see what Dr. Tami did to this case.
So in this case, we select orbital atherectomy. Atherectomy was done using OAS Diamondback 80K forward motion for 4 run and 120K forward motion 1 run at left main.
Can we see the slide?
Oh? Can you see my slide?
Yes.
Yeah. Can you back? I mean, before ballooning, just
before
when you do
balloon. Oh, okay. Okay.
When you run the OAS.
we can proceed, doctor?
Yeah, okay, yeah.
Okay. So we did further the pre-dilatation using 2.5 times 15 millimeters Scorflex balloon for LAD and 3.5 times 13 millimeter NSE aperta for left main in moderate to high pressure. I first showed reverberation, but in several, we also see crack, especially at proximal site. And lumen was quite enlarged, but CN still remain. Some crack we can see. CN was still there. So what should I do next?
Okay, any comment from panelists? Yeah. After seeing the results of OAS and then another scoring balloon and NSC alpha pre-dilatation, that's the result. And then
Yeah, may I comment, Dr. Rifqi
yes,
Barudin?
please, Dr. Barudin,
Yes.
yeah, please.
I'm not sure when you did balloon expansion using 3.0, whether the balloon is expanded well in the ostial to proximal LID.
I use 2.5 Scorflex balloon.
Scoreflex balloon and then NSE.
Yes, for LAD, NSE 3.5 by 13 for left main.
Yeah, the balloon, the 3.0 will expand it or not? Not so clear.
Okay, we can go back. It's quite okay for me. Yeah.
Yeah, in the distal part, I think it's well expanded.
Yes.
How about the proximal? It's very small.
This one.
Yeah, some irregularity, I think. Yeah.
I think it's, I'm not quite sure. I think it's bubble.
It's bubble. Yeah.
Yeah, I think.
Meaning, yeah, if there is expanded well and it's 3.0 until 3.5 and 20 atm, the maybe almost 20, the almost 4.0 millimeter, the diameter of the balloon in the 20 atm.
For the NSE.
Yeah.
It was the moderate pressure, 28 m. Maybe 20 m, probably by 3.6 or something.
Okay. Yeah. So in this case, maybe is stent could be expanded in this case, but not sure because in your IFUS there is some nodule calcified
Yeah,
that
still CN. Yeah.
maybe need more aggressive what we call reduce the calcification by orbital atherectomy. Thanks, Doctor.
Okay, thank you very much, Dr. Barudin. Any other comment? Dr. Yahya or Dr. Yasin?
Yeah, I think Dr. Fauzi already gave us a hint about what to do. The benefit of choosing orbital is we can just use a single burr size and just play with the speed of the burr, and then we can like get the size that we need. Maybe the size in the proximal LAD to left main is a bit bigger than 3.5, so maybe we need to be more aggressive in that area. Maybe need a higher pressure of NSE balloon, or use a bigger burr. But I think increasing the speed is enough.
Okay. Dr. Yahya, any comment?
Yeah, I agree. We use the highest speed to enlarge the lumen, and then use the high pressure balloon to see the size, and and so the stent will well exposed to the vessels.
Okay. Maybe Dr. Fauzi and
Maybe
Dr. KK, Nick. Yeah, please. Any comment from Dr. Fauzi and Dr. KK?
Yeah, this is a tough case because you already used the aperta as well. So if you at high pressure at for the 3.5, which means that if you put orbital in, there's a bit of risk, or even if you put rotor in, there's a bit of risk. In my practice, I would use the shock wave. I'm not sure whether that is available, but if you did have, I would use a shock wave. If not, I would just keep doing more ballooning, if need be, using an OPN. But I think there's really some risk there to perforate. So you probably have to have contingency plans. Thanks, over.
Dr. Fauzi?
Yes, it is interesting that the ablations in 80K, which is the orbit is smaller than 120K RPM, is at the whole vessel from the left main to the mid LED, but at the back when you back to the end, you perform another run of OS 120 back to at the left main side. It means that you would ablate the bulk more than the LED, we know that the LED territory, there is some part of the eccentric calcification. In the eccentric calcification, we have to be cautious if you are using 120K or we use forward and backward movement in OR. And in the concentric calcification, it's okay. You are using upward and backward based on the vessel size, which is already know that the left main, which is a very big, that's why, and then very tight stenosis, that's why you are use 120K. If after a rotational atherectomy, it is better to use IFUS again to whether the IFUS can cross the lesions before you are doing anything before. If you are dilate the lesion after atherectomy, it is nicely you are put the you are still maintain the wire OS wire there, and then you are using another wire to evaluate using IFUS, which is we know that the IFUS not quite demonstrate not quite sufficient successful ablations. That's why the balloon unable to inflate well. And then I think we need rotational orbital atherectomy again, using especially in the proximal part of the left main and the proximal part of the LED and the distal part of the left main. Maybe at the left main part, we use very slowly very high speed in the slowly movement. High speed means that 120, but slowly movement, very, very slowly to have a debulk more on that side. Yeah, thank you.
Okay, thank you, Dr. Fauzi. Just to make sure, Dr. Tami, did you do another run after NSE? I mean, another run of the OAS after NSE dilatation?
Right after this, you mean, doctor? Right after this one?
After NSE pre-dilatation, did you do another OAS run or not?
Yes.
Yeah.
Yes.
Okay, okay. Okay,
Dr. Rifqi,
yes,
before we are
yes,
proceeding to the what Dr. Tami did,
yeah.
there is a question from participants to 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 me and Dr. KK. To me, Dr. Yusuf asked about how to perform balloon test safely in calcified lesion when intracoronary imaging is not available. If you are trying to have sense whether this is a calcified lesion or not, you use a balloon based on distal size vessel, lumen size vessel, because you are using angiography, and then based on distal lumen size, and reduce the size to a quarter, and then make it high high pressures, but try to use a smaller balloon than the distal vessel, which is and that if there is a still tight at that point, stop it and don't do anything more, because it could be very heavy calcified, which you can handle using a balloon. And then at that point, you have to use a atherectomy device. So don't use a bigger balloon to inflate at the very tight stenosis, because the balloon can go up and then will dissect or rupture at the proximal side and the distal side.
Sorry,
Thank you.
Dr. Fauzi,
okay.
just to
Thank you.
clarify, is it a semi-compliance balloon or could we use a non-compliant balloon
Yeah,
for
better
the
you
balloon testing?
to use a non-compliant balloon one. Yeah, and the size is important. Use based on the distal size, and then you are can use a quarter, reduce the size, because we don't want to dissect it, and we don't want to have perforations. Yeah.
Okay, thank you.
There is a question to
Yeah, Dr. Yeo, yeah. There is a question from the audience, Dr. Yeo. Could you
Yes, I
explain
saw.
more? Could you explain more on the benefit of extra support wire in reducing wire bias?
Oh no, I want the wire bias. Sorry, I may have not been clear, but the extra support wire has bias, mixed bias, and that bias helps me get through calcified areas, and even if it is not the optimal area, it breaks any concentric calcification if there is concentric calcification. So I kind of want the bias. Now there are some risks, of course, for the right coronary artery, and sometimes the osteocirc, it can be very tortuous. And if you have those lesions, a floppy wire is better. But otherwise, from experience, the extra support wire, should work most times, and it's because I want the wire bias.
So it means that you actually just creating the wire bias to get more benefit with the extra support wire, right?
Yes, the roto, yes.
Okay, thank you. And then there is another question also for you. Is there any difference on how we should inflate non-compliance scoring balloon, NSA aperta, or Wolverine in calcified lesions?
I think the whole thing is to go not so fast, because you don't want to rupture the vessel or rupture the balloon. So generally I will go a bit slower, but most of us are somewhat impatient, so I just go slower, but I don't actually count, I just go slower, especially for the Wolverine. For the NC score flags and the aperta, as well as the angioscope, I go slower, but I don't count the seconds. I just subjectively go slower. But the Wolverine, you really have to be careful going up and down because of the metal blades, especially when you deflate.
Yeah, okay. So just go slow, especially for Wolverine, maybe go slower to inflate. Yeah, okay. Okay, and okay, please, what we have done by Dr. Tami, please.
Okay. As you can predict, Dr. Rifqi, we have another round of OS. It was used in high speed for several runs, both forward and backward run. Also, with addition of Scoreflex and NSC aperta at higher pressure, higher than before, it's quite probably expand well, the balloon. And then the contrast injection showed residual eccentric calcification still at the distal left main. At this point, we worried if we put the stent now, we will compromise the circ because of the shifting of carina, because we appreciate before there were calcification at LAD just opposite of the circ. So we did more OAS, both forward run and backward run, especially at proximal and left main, proximal LAD and left main. We proceed with kissing balloon using the same balloon, Scoreflex 2.5 by 15 low pressure at ostial circ, and aperta 3.5 by 13 millimeter at ostial LAD for 14 atmosphere. We then proceed with stenting proximal to mid LAD using 3.0 by 38 millimeter DES just before the diagonal, first diagonal, to avoid overlapping stent at ostial diagonal. Also, we did flaring the proximal part. And we put the DS 3.5 by 26 millimeter overlap with the previous stent to ostial left main. We did pot using NC balloon 4.5 by 88 millimeter, high pressure at left main. IFUS run after stenting showed quite good expansion and apposition at LAD, and with no stent edge dissection. We can see here there's a there we go. Minimal apposition at left main because of the calcium nodule. Yes, there we go. Okay. The angio showed acceptable result, no compromise of the circ, and quite no compromise to diagonal as well with Dimitri flow. Thank you.
Okay, thank you very much, Dr. Kami. Very challenging and interesting case. Dr. Fauzi and Dr. Yeo, maybe can give a last comment, please. Maybe Dr. Fauzi first regarding the final result.
Yeah, I think we are quite satisfied with the final result. In this particular strategy, which is how to deal with the bulky calcified lesion at the distal left main, not only the operator did orbital atherectomy run very gentle with 100 to 120, and then goes back. And then, but not only that, she tried to crack exactly using a kissing balloon, pre-kiss PCI, to make if we are, let's see, if we are using just a balloon to open up the LAD left main, might be the balloon looks like inflated well, but actually it goes to the side, healthy side, at the carina side. If you are putting the stent at the time, it's going to compromise. And then at that point, the operator putting another balloon to the circumflex to make the crack to the calcified side. So at that point, it will expand the calcified side, and then will make a stent is a sufficient expansion. That's why we look at the IFUS finding, which is a very good expand stent. The other point is there is some malappositions because of multiple calcium nodule there, which is very difficult to have apposition well in this like a mountain calcified in the left main. So I accept the result, and then congratulations to have such a wonderful demonstration. Thank you very much.
Okay, thank you very much. And Dr. Yeo, please give a comment on how about using the two scoring balloon for kissing at the bifurcation with the wide angle?
I think that's possible, but I generally don't do that because I'm not sure how the two cutting elements will interact. But if you have the balloon out and I think it's reasonable to try. It's just that I don't usually do that. It doesn't mean you shouldn't do that. It's just that wouldn't
I
be
think
my
the operator is using because of the balloon is already there.
That's right. That's right. So I think it's probably
because
okay.
of
But you don't want to do it with a Wolverine, for example.
Yeah.
So I think it's reasonable. And then for dissection, the earlier question on the chat about how much dissection is acceptable, I think there's no good answer. The guidelines and the rotablator instructions for use just say significant. So there's always that risk. I think if you see a dissection flap, you probably shouldn't do it. If it's only on IVUS and nothing else, otherwise it looks okay, you may get away with it, but just recognize that there's going to be some risk if you use atherectomy, whether CSI or rota, when there is a dissection. Typically, a 2O balloon will not cause enough of a dissection to cause a problem, but we did have one case where the previous operator used and ruptured many balloons, and there was all sorts of ugly dissection, but it burritoed nicely.
And how
Dr.
about
Rifqi, sorry.
Yeah.
Sorry, may
Yeah,
I ask
please.
Dr. Yeo, you've mentioned a bit about lithotripsy, shockwave. Do you think it will be beneficial using lithotripsy in this case?
Yes.
And what's your strategy if we had lithotripsy, shockwave in this case?
Yeah, so Tami, when she showed her case, after the 3.5 aperture didn't fully expand, I would use shockwave. I would put up a 3.5, and then and sometimes it cracks enough of the calcium such that the next non-compliant balloon you put there actually works.
So the first one is the same, like rota or orbital, and then for the proximal part, when you need a bigger size, you use the shockwave there.
No, that means you rota and then you balloon. Balloon got, if there's residual narrowing or waste or stenosis with the balloon, or inadequate expansion of the balloon, then I'll use shockwave.
Okay, thank you.
Because shockwave is very expensive, I don't take it out straight away. I only take it out if I have an NC balloon of some sort that doesn't work. Then I say no choice. Yeah.
Okay, regarding step by step, if we plan to do some rotational or atherectomy device, and how about using like a scoring balloon before atherectomy? What do you think?
I think well, I don't have enough experience with orbital. I use mainly roto, but I would say that I would avoid it if I can, but sometimes you don't have a choice. If you don't have a choice, just be very aware that you can wrap the dissection flap with your burr. So I would generally advise against it. If you're like I said in my talk, if you think about rotablator, you probably should, or orbiter, you should probably just do it rather than, regret one way or the other.
Yeah. Okay. Okay. Thank you very much, Dr. Yeo and Dr. Fauzi. Okay, I think we have learned from this very challenging and interesting case that we might have to be careful if we want to do some plan of rotational atherectomy using a rota or OAS. We have to be careful if not to create a dissection or to minimize the dissection, because the rotational of the device can wrap the dissection. Yeah. So I think we have to be careful, and then and the intravascular imaging is very important, as we've seen that it's recommended from all of guidelines if we plan in patients with a rotational, with patient with a calcified lesion. So it's very important to do intravascular imaging, do some scoring with the calcified score, using the intravascular imaging, and then how to deal with the rotational or OAS device, and then also it's also important to choose wire. Some operator familiar with the floppy wire, but Dr. Yeo showed that extra support wire also safe, and even sometimes give us a benefit to have a guide wire bias that close to the calcified lesion, so we can have a more effect on the doing a rotational atherectomy or OAS. So thank you very much again for all of the speakers, panelists, and presenters for your great contribution on this topic, and hope we learned something from this meeting. Thank you very much.
Thank you very much.
Thank you.
Thank
Thank you
you.
very much,
Thank you,
Doctor.
Doctor.
Thank
Thanks
you. Good
thanks
night.
for all.
Bye-bye.
Good night.
See you.